genetics. Is it really play important role? Yes. I have seen in my clinic many times father and son or first degree or second degree cousins, uncle and nephew, they are coming for the same problem, premature ejaculation and all. So yes, it is genetically important. So today's my topic is more theoretical rather than practical, though even I tried something different. As you all know that ejaculatory disorders are most common type of dysfunction. The broad range is premature ejaculation, retrograde ejaculation, delayed ejaculation and unejaculation, but mainly classified as premature and delayed, categorized as lifelong versus acquired, generalized versus, fine, yes. So, categorized as lifelong versus acquired, generalized versus situational, mild, moderate, severe, natural, variable premature ejaculation and premature like erectile dysfunction. Let's start with few cases that will help you to understand about the etiology, because treatment is highly dependent on etiology. Case first, a 40-year male, non-satisfying sexual relationship, premature ejaculation since 16 years of age, one IVF baby, the diagnosis is primary premature ejaculation. Case 2, a 30-year-old male, love marriage, both never discharge in vaginal intercourse, but discharge in masturbation, no child. Diagnosis is delayed ejaculation. I will discuss it later on. Case third, 37-year alcoholic male, diabetic, premature ejaculation for 1 year, multiple sexual relationships, premature with all, and diagnosis is secondary premature ejaculation. Case 4, it's related to my previous lecture last year. 29-year-old young married male, unable to discharge, past sexual abuse history is positive. The diagnosis is sexual aversion disorder. Why I discuss the case? Because etiology is very important in the treatment. Every case is different with different etiology, different prognosis and all. Pathophysiological etiology of ejaculatory disorder, basically established through medical, psychosexual and psychosocial history. Etiology is usually multidimensional, resulting from men's biologic ejaculatory latency being affected by multiple organic or psychological factors in varying combinations. The factors are usually neither independent nor mutually exclusive. Both categories overlapping and including a combination of factors. Let's start with premature ejaculation. Exact etiology is still unknown, though we will discuss about the role of serotonergic receptor, 5-HT receptors. Stimulation of 5-HT2 receptor leads to delayed in ejaculation, while postsynaptic activation of 5-HT1A receptor causes early ejaculation. So, hyposensitivity of 5-HT2 receptor and hypersensitivity of 5-HT1A receptor causes premature ejaculation, and this is very important in the treatment of premature ejaculation pharmacologically. But serotonin hypothesis mainly explain about lifelong premature ejaculation, and distinction of 4P syndrome also suggestive of different etiopathology, mainly biological and psychological. First about biological. Genetics. Is it really play important role? Yes. I have seen in my clinic many times father and son or first degree or second degree cousins, uncle and nephew, they are coming for the same problem, premature ejaculation and all. So yes, it is genetically important. Then polymorphism of 5-HTT-LPR gene, that is serotonin transporter linked promoter gene, SS and SL genotypes having longer time than LL. Dopamine transporter gene, that is DAT1 gene polymorphism, is also associated with premature ejaculation. Increased penile sensitivity and higher cortical representation of pudendal nerve, that is hypothetical hyperexcitable ejaculatory reflex caused by hypersensitivity of glands. And this is very important. It is very common in primary premature ejaculation. In that case, sometime local anesthetic may help you. Biological factors, endocrinal, like diabetes and hyperthyroidism. Urological, 26% mean with prostatitis and chronic pelvic pain complaints about premature ejaculation. In neurogenic, multiple sclerosis, peripheral neuropathies, medullary expansion process or spinal cord tumors create the problem. Drugs, they are important, though we have 2 previous lectures, but amphetamine, cocaine and dopaminergic drugs causes premature ejaculation like apomorphine, pramipexole and bromocriptine. Chronic renal insufficiencies, low magnesium level in the seminal fluid. It's a study only, don't know very much about this. Varicocele in few cases. Sexual dysfunction like ED and hypoactive sexual desire disorder. And nutritional, vitamin B12 deficiency because of tiredness, fatigue, lack of energy and many factors. But the lot of studies available about vitamin B12 deficiency. And in fact, I do regular practice in my OPDs. I prescribe vitamin B12 injections in the treatment. And patient reports, sir, वो जब injection दिया था तब बहुत अच्छा timing था. So I repeat vitamin B12 injection after 4 months or 6 months. And so wonderful results. Not in all, but in few cases again. Now important is psychological factors. This is anxiety. Whether this is performance anxiety, generalized anxiety disorder, sexual anxiety disorders, occupational anxiety, family anxiety, or non-specific anxiety. We regularly perform HAMA, means Hamilton Anxiety Scale, or Beck's depressive inventory in our OPD in sexual patient. In last year also I suggested a performa about how to evaluate a patient for sexual disorder. This is very important to evaluate about basic anxiety, basic depression for etiopathology. High arousability, learning by excessive masturbation, especially rubbing on bed. Because when the person do masturbation by rubbing, they are very sensitive for female body. Whenever they go to relationship, they immediately get discharged. Just because of their habit of rubbing on bed. And they get satisfaction by that. Porn watching history. They are always half discharged. So this is very important about the porn, use of porn watching, frequency of porn watching, and associated masturbatory practice. So make it regular during your psychosexual evaluation about the porn watching history and masturbation history. This is very important. Psychological, poor self-body image, shame and guilt. Frequency of sexual activity, sometimes long gap, especially with the IT people in the metros. People don't have time for sex and then don't have time for partner. They're hardly having intimate once a month and they complain about premature ejaculation. Early sexual experiences, they are very, very common. Rust sexual encounter. How was his first sexual experience? Who was the person? Sometimes a very senior lady. Child sexual abuse is more common in male child rather than female child. This is worldwide study. But this is underreported. So this is very important. That first sexual encounter was which person? Where? Time in foreplay. Then fear of being seen or heard. Unsafe place. Especially in the joint families. Or where the room is a crisis factor. एक बहुत अच्छी मूवी आई थी किसी ने देखी तो सांड की आंख. कहते कि एक ऊपर रूम है, मंडे इसका, वेडनेसडे इसका, ट्यूसडे इसका और संडे जिसका मौका लग जाए उसका. सो प्लेस इज वेरी इंपॉर्टेंट. Sexual abuse, orthodox upbringing, faulty techniques or lack of awareness about ejaculatory control. Onset of PE is important to establish the cause. Lifelong, mainly it is genetic, neurological or psychological, acquired due to comorbid conditions, stress or drugs. A specific partner, there might be intimacy issue. And very important is some young patients may report premature ejaculation while masturbation or never have an actual sexual intercourse. Nowadays, young guys coming to the OPD, 15 years, 16 years, 17 years, sir, I have premature ejaculation, while they have never tried. The reason is either porn watching or either excessive masturbatory practice. Now the etiopathogenesis of delayed ejaculation. This is least common and least studied male sexual dysfunction. Estimated prevalence of 1 to 4% of the male population, known as inhibited ejaculation. It can be a normal phenomena, like case 2. Few males need 30 or more minutes to reach orgasm. They might be blessed, depends on female partner or their self-choice. Broadly, etiology is again psychological and biological. Here, psychological factors are more important in delayed ejaculation, traditionally implicated as predisposing and or confounding factors like insufficient sexual stimulation, whether this is physical or mental. Again, autosexual orientation. They prefer masturbation over partnered sex, like in case 2, unusual practice 2 to 3 times in a day. Self-stimulation is personalized in the speed, pressure, duration, intensity, and focus on a particular spot of sensitivity, which is necessary to produce an orgasm. And that's why they prefer masturbation over vaginal intercourse. Disparity in fantasy and real sex life. This is again disadvantage of excessive porn watching. Paraphilic inclinations. Age-dependent factors like cognitive decline, low libido, and religious. Again, hostility and anger. Inability to relax in presence of partner. Fear of hurting. I have a very good case. 2 IT people, they were somewhere in the Europe, having live-in relationship, and they decided we will have proper sex after marriage only. Because they were in live-in relationship, they got married, and even after 3 years of marriage, they don't have sex because they don't want to create the situation, or the husband don't want to give pain to the wife for first intercourse. Fear regarding pregnancy and fertility issue. Fear of loss of control. Fears of abandonment or rejection. Fears of intimacy and loss of autonomy. Guilt or body shame. Depression, anxiety, and other disorders. Orthodox and over-religious upbringing. Biological factors. Medical disorders affecting central regulatory mechanism or peripheral nervous system, that is injury to pelvic nerves that control orgasm or nerve damage to the spinal cord. Neurological disease like multiple sclerosis and diabetes. Diabetes can affect in any way. Diabetes creates autonomic neuropathy and microvascular involvement. Aging, because decreased penile sensitivity and other sensory loss, some genetic factors, some congenital deficits affecting the male reproductive system like Wolffian or Mullany duct abnormalities, prostate surgeries like TURP, prostate removal, certain infections like UTI, hormone-related conditions like hypogonadism or hypothyroidism, alcohol. Again, this is very important because during heavy drinking, 59% of the men experience erectile dysfunction, 48% reported delayed ejaculation, and 84.4% people complain about some kind of sexual dysfunction. Role of medications. It was very well said in last 2 lectures. Just highlights about antidepressant, antipsychotic, anti-epileptic, antihypertensive, alpha-adrenoreceptor blocker, PD5 inhibitors, 5-alpha reductase inhibitors, certain diuretics, opium, cannabis. The thing is, onset of D is again important to establish the cause, because the treatment depends on the etiology, lifelong, acquired, global, or situational. Now, retrograde ejaculation. Semen is passed in retrograde fashion into the bladder as opposed to the out the urethra. 3 potential causes. First is anatomic, that is following bladder neck surgery or from a congenital process. Neurologic, disorder that interfere with the ability of the bladder neck to close during emission, such as diabetes mellitus, retroperitoneal surgery, prostate surgery, or again multiple sclerosis. Pharmacologically, especially alpha blockers like tamsulosin, sildenafil, etc. Final thoughts. Ejaculation disorder can be difficult to overcome. Many people prescribing medicine for years, and even we don't have the results because perhaps we didn't work on etiology. We didn't evaluate patient properly. However, with support, symptoms can be managed and more normative sexual experience can be shared. Since ejaculation disorder may be a learned behavior, this is very important. It can also be unlearned and new message can be adopted. Sex is normal innate behavior of human being and it should be pleasurable. Simple a joke apart, there is nothing like premature ejaculation. The truth is, women have habit of arriving late everywhere. Thank you. Any question?
Thank you, Dr. Akhil. We'll open for discussion. Some questions?
So you discussed it very well, sir. Thank you. Congratulations.
Thank you, sir.
But you have not defined what is the duration of premature ejaculation. What do we call it as a delayed
Sir,
ejaculation?
actually my topic was etiopathology.
Because
so I didn't discuss about the definition of...
because each individual has some perception, and after seeing the pornography, they will have varying ideas. So when we'll...
Sir, actually definition of normal ejaculation varies from different races. A normal study says that if 2 to 5 minutes a man can perform, that is a normal ejaculation time, depends that both of the partners should get orgasm. If a person is, your partner is not able to get orgasm on repeated 3 times and time is less than 2 minutes, then it is called as premature ejaculation. What I know or what I can understand. This is DSM-5, perhaps, not. Yes, but I think this is DSM. Yes, yes. He will cover because that was not my topic. My topic was simply etiology and pathology. I tried to explain little bit, but my main focus was clear on etiology. Then how you should evaluate the patient during your routine OPD. What we do regularly, like I have a perform of MSD evaluation, this male sexual dysfunction evaluation or female sexual dysfunction evaluation, where we regular work on, we use the scales like Hamilton Anxiety Scale, Beck's Depressive Scale. We have a point for porn watching, masturbation, child abuse, marital MQ scale. We evaluate every patient, and it's almost about 1 to 1.5 hour performa. That the patient, when the patient evaluated properly, we get the main cause, etiology, and then the treatment is very easy. Thank you.
One more suggestion. There is a secondary premature ejaculation. Normally, it is the beginning of erectile dysfunction.
Yes.
So we can manage it. That premature ejaculation. If it is secondary, first drug of choice is sildenafil citrate or PDE5.
Yes, PDE5 inhibitor is always and always, because secondary PE is mainly due to like some kind of infections, or most important cause is diabetes and alcohol. So first thing is improve lifestyle. We have to focus on improve lifestyle. Stop smoking, alcohol, start running, decrease your sugar, decrease your oil, and all things. Healthy habits makes you healthy, makes your sex healthy. History says if the person is having sex more than twice a week, then chances of cardiac disorder decreases by 80% and chances of neurological disorders decrease almost 84%. Yes, sir? Such a chances. Every day. Every day is very good because, again, sex brings a mental peace to your mind and brings close to your partner. So if a happy married life started with happy bedroom habits. Thank you.
Thank you, sir. I'm a psychiatrist, Dr. Parthiban. I have one question, sir. Since it's etiopathology, any types of masturbation which has an impact on ejaculation, delayed ejaculation, sir? Because I have few clients who have specifically prone type of masturbation instead of handheld masturbation.
Sir, the thing is, as I discussed in case second, if the person is having masturbation daily, then there is how he can get orgasm or he can get attraction for a female, because it's an autosexual orientation. When there is autosexual orientation, there is a chance, in fact, in every case, there will be delayed ejaculation.
The real challenge is managing this patient in long run is very quite difficult with the in presence of partner. I may need an expert's opinion. May not be relevant etiopathology ways.
Perhaps I couldn't understand your question.
No, sir. This type of prone type of masturbation or excessive masturbation which has impacting their couple sexual life in ejaculations. So the management aspect, so one is sensate focus technique that we try.
Management is first an important step is stop masturbation. At least self-masturbation. If the person want masturbation, it should be by partner. Once he will start masturbation by partner, there will be vaginal intercourse. More and more chances for vaginal intercourse. So first and important step is stop masturbation by self. This is very important step. I think more than 90% you will get the success.
Thank you.
I think. Thank you.